small group today, which is good. Be nice and cozy. So again, my name is Amoy Jacques. I work as the program manager at the Collaborative and Critical Research for Equity in Health or Transformation in Health at the University of Ottawa at the Faculty of Health Sciences. And I'm presenting this presentation on behalf of Dr. Josephine Etoa, who is our lab director. And we were quite instrumental in both of these projects that we're mentioning. So because I'm going to be speaking for quite a long time, I'm going to try to create a story of the content around. Hello. We're a small group, so we'll just get cozy. So I'll just provide some context around these two presentations. So this first one, HIV-Related Stigma and Discrimination, multiple perspectives of issues influencing CAD or Canadians of African descent women's health. This particular project came at the aftermath of COVID. And the next presentation that I will present on the next presentation was at the peak of COVID. So you will see from the quotes of the participants some of the urgency around some of the services that were impacted. Sure. Trying to get on.
Test. Okay.
Perfect.
Wonderful. Okay. So we're back in business. So I'll be providing quite a bit of context so you can understand just some of the urgency around the levels of care or the lack of access that were experienced by our participants. So this first study is really situated to give voice to particularly Canadians of African descent women, or CAD women is what we call them, which is used interchangeably with ACB women, and giving them voice to their HIV experience. We need Sarah Emily back. It's not working. Yeah. Oh. Down. Okay, perfect. Thank you. Okay, so the background of this study is that within Ontario, Canadians of African descent represent only 5% of the population, but according to a OHSI report, account for 26% of new HIV diagnoses. And so this particular statistic is quite startling when we think about the fact that there are not a lot of ACB people within Canada, but we are significantly overrepresented and disproportionately burdened by HIV. And so when we narrow into that population and we look at specifically Black women, we don't have a lot of data within Canada around our experiences when it comes to HIV and service delivery of care. So studies like this is really adding to the emerging body of literature around Black women and their impact of this disease. So, as I mentioned, to date, there is very little primary intervention or research that's been done to facilitate the limit of access to HIV treatment or prevention measures among Black women. CAD women experiences are largely neglected in the HIV scholarship. And despite women representing 2/3 of all HIV cases in Canada, they were the only focus of 19 research initiatives. So there's quite a lot of work to be done. And within the context of COVID, there was I would say, an outcry within or the ACB community as well as within research to really address why it is that we have very lagging race-based data here in Canada and why we're always having to rely on US data, which quite frankly cannot be used within the Canadian context. So studies like this, it's really good because we cannot provide any impact or any change to what we can't measure. And so when we have these studies, it just provides evidence for further research, for funding, and it also provides evidence for intervention. So this particular study aimed to do three things. First, to identify barriers that impede access and utilization of HIV prevention, testing, and treatment. The second, to improve HIV health services for CAD women during their reproductive ages. And the third was to meaningfully engage CAD communities and HIV health providers to develop tailored interventions for this target group. So in terms of what we were able to accomplish with this project, aims 1 and 2, we definitely did that. And aim 3 is more of a long-term goal. So in terms of our methodology, most, if not all of our studies apply a mixed methods approach, which means that we had in-depth interviews, focus groups, as well as an online survey. The online surveys were for service providers specifically, and the focus groups and interviews were for CAD women. And the frameworks that we use are the socio-ecological model, primarily because we're dealing with a lot of different actors at play. So ACB women, community partners, different community organizations that really have to pull together to understand this wicked problem. And when we're looking at the issue of stigma and discrimination, we're looking at it from several layers. So from an individual layer, community layer, institutional, as well as systemic. So because the problem is so complex. And when we look at community-based research, we're looking at how are all of these actors, specifically ACB participants, how are they involved in the research process? And so they journey alongside of us to answer some of these wicked problems that we have and provide recommendations that eventually will translate, or we're hoping to translate, into policy. And so with respect to the qualitative data that we obtain, we use Braun and Clark's thematic analysis approach. So with respect to our study participants in terms of their demographics, so for the in-depth interviews as well as the focus group, we had a similar number of people. Within our focus groups, we had about 7 to 8 people in each. And the age range was quite wide, 18 to 69. And as I mentioned before, the racial background were CAD women. So this specific data set is going to focus on the focus group findings, the barriers to accessing HIV-related services among CAD women in Ontario. So we're looking at these major themes. There were other themes within our data set, but these were the ones that were most prevalent and aligns with the Black Mental Health Conference that we're at. So stigma, discrimination, and fear. And we're really going to look at giving voice to the women that participated in these focus groups and what they had to say about these particular issues. So when it comes to stigma, factors contributing to stigma and hindering access to HIV-related services, 2 main factors were prevalent. So lack of HIV knowledge of transmission, self-testing, prevention, and care, as well as religious beliefs about abstinence and chastity. So when it comes to stigma, one participant said, so here people don't really recognize HIV. They're not very updated about it compared to where we come from, because where we come from, you see TV commercials about it, like everywhere they tell you where to go for help, which is not here meaning Canada. So here you talk to somebody who has grown up here and they don't even know what HIV stands for, So I think the biggest challenge is we have no awareness about HIV here in Canada. So just to give some context to this, particularly participants that were from African countries as well as the Caribbean would have more access to HIV knowledge, would have more access to clinics, as well as different campaigns within the respective countries would be posting abstinence information and information about HIV. But what this participant was really trying to highlight was that a lot of immigrants come here to Canada, they don't hear about HIV or its prevalence or how it still is significantly impacting our communities. And so there's this I guess, belief that it doesn't really exist here or it's not as detrimental as it is back home. And so we know that's not the case because I just mentioned the stats about it's affecting 26% of our new cases are represented by 26% of ACB women in particular. So when it comes to stigma relating to religious beliefs about abstinence, this participant mentioned, and I think it also stems from the fact that many times we have never had proper conversations about sex with our parents, and there's shame when we do have sex. So the idea that if we contract a sexually transmitted disease, well, we weren't supposed to be having sex, or you weren't supposed to be, you're supposed to be keeping your legs closed, or you're supposed to be praying this thing away. So there's just a lot of tug of war of emotions and ideas and inconsistent pressures that don't make any sense and they don't add up. And so one of the other pieces that we see when it comes to stigma is that we don't have honest conversations within even our homes or our churches or social network to fully understand HIV transmission. So my time is running out. So I'm going to talk about discrimination very briefly. Discrimination was another prevalent theme when it comes to its effect on race and immigration status, as well as inappropriate funding models for HIV medication. So I'll just take this quote because, first of all, it's something that we cannot deny that we're in a country where we just migrated to. We weren't born here. So some people, not everybody, but some people look at your status, and they think that you might not be good enough for some services, or they think that you shouldn't be given priority. So this participant is really struggling with this immigration status notion and knowing that they actually do need services, but their health condition is not being prioritized in a way that is reflective in the statistics that I mentioned at the very beginning. So I'm going to skip over this so we can address FAIR. When it came to FAIR, there were some participants who mentioned that this contributed to their access to HIV services when it came to language differences as well as privacy and confidentiality concerns. So I'm just going to go to the privacy one because I thought there were some interesting pieces here. And I'll read the second quote. If you don't trust your own mom or your own sister, this is a thing you can tell them. This is the thing you can't tell them because of the way they're going to treat you. And sometimes it's not the HIV killing you, but the way they treat you will stress you and can make you quit and can make you sick and die before your time. And so even within our communities, there's a lot of issues around transparency, who's going to keep your diagnosis to themselves, or is it going to be spread throughout the community? And there's still a lot of stigma and shame around that. So this person was just really stressing that there's a lot of fear in even disclosing the diagnosis. And so when we're dealing with these very complex challenges, it's difficult to try and find a way forward. What does that look like in terms of making a significant impact when it comes to HIV access? And so some of the recommendations that came forth from the data set, as well as aligning with the research, is innovative and targeted interventions through policy change. And I'll talk a little bit about that in my second presentation, and community practice to improve HIV healthcare outcomes. Also strategies around critical health and racial literacy, which I'll talk a little bit more in my second presentation, as well as implementing a peer equity navigator model. And so when we talk about critical health literacy, we're looking at this as an intervention to really educate people around not just understanding health information, but how do you analyze it so that you can make critical decisions about your healthcare. And we know that post-pandemic, particularly racialized communities have had a challenging time dissecting the information that they received. We received a lot of misinformation. We received a lot of disinformation. And so this really impacted their abilities to seek adequate care. And we saw this with COVID-19 vaccines, as well as with other challenging chronic ailments like HIV. So critical health literacy is a tool, it's an intervention to help train our community members to understand and dissect health information in a way that is going to help them improve their health outcomes. And so another phenomenon that we saw within COVID-19 was a lot of disengagement of our ACB community members from the community. And so implementing a peer equity model just allows our own ACB community members to be trained in certain disease areas so that they can go out and educate and empower our communities to re-engage with the healthcare system. And so that is it for the first one. All right, so I'm going to go through these slides a little bit quicker because some of the context was covered, but just to reiterate, so this particular study, Understanding Stigma and Discrimination in the Context of Healthcare Access for African, Caribbean, and Black Communities in Canada during the COVID-19 pandemic. And so I know we're spending a lot of time talking about COVID and this, phenomenon that we've all gone through and what does it all mean? This particular study happened at the height of COVID. So we're looking at around 2021, 2022. And so the reason why we have to focus on this is because in the unfortunate event we go through a second pandemic, are we actually better ready to actually handle getting access to care? And I'll let you sit with that just for a moment. So a lot of recommendations and studies have been done around the ACB community just to really arm us with the right information, the right access to care, providing community resilience through different community agencies, as well as arming us with a sense of agency so that we can go out and better care for ourselves in the event something detrimental happens within our society that had a global impact. And so this study really wanted to look at understanding what were some of the intersections of COVID-19, sexually transmitted bloodborne illnesses, as well as mental health, and what were some of the ways in which that our ACB community members navigated that time. To this, the last. Okay, there we go. So I gave a bit of background. I'm going to go through the AIM methodology very quickly, but get right into the focus group findings. Okay. So as I mentioned before, ACB populations have a higher health inequities due to the social determinants of health. And so we see that even with COVID-19, there's been an exacerbation of various chronic ailments like diabetes, HIV, obesity. And so I'm not going to spend too much time on this. But what we saw during COVID-19 was an exacerbation of mental health distress, as well as other taboo topics that we don't necessarily talk about openly, like substance abuse, domestic abuse, as well as access to STBBI services. So as I mentioned, the aim of the study was really to understand the services that were related to STBBI prevention and treatment, and how this was impacted due to the containment measures during COVID, as well as what were some of the underlying factors or barriers to accessing care. So I'm not going to spend time on this slide because it's similar to the previous study. As well, with respect to this particular study, so it wasn't just focused on ACB women, it was focused on ACB community members at large. And we had a mixture of academics, researchers, as well as community members within this participant demographic. So when we were looking at our findings, we really had to try and understand, how do we define access? What does that mean? What does that look like on a system level? And so we use the LaVex framework to really define access as the opportunity to identify, seek, reach, obtain, or use healthcare and to ensure the fulfillment of the needs for these services. So with this particular framework, we're looking at two different prongs. We're looking at system-facing issues, so affordability, approachability, access, as well as patient-facing issues, so the ability to seek and reach and obtain and pay for services. So the two main themes that came out of this particular study were stigma, again, at multiple levels, as well as discrimination at the system level. So stigma manifested itself internally in this particular study and was deeply rooted in the problematization of mental health disorders. So within the ACB community, no one necessarily wants to raise their hand to say, hey, I'm going to go see a counselor because I've been diagnosed with psychosis. I know we've had a lot of talk about that in other presentations, because there's often a misconception that, you know, you're crazy, you're not able to make decisions, you need to be casted off out of society. And so no one necessarily wants to raise their hand and say that they're having mental health issues. I think we're having better and more open conversations around this. As especially the millennial generation, that's really opening up for our elders within our communities to have more conversations around what kinds of supports do you need if you have a mental health disorder. And so this particular quote highlights that this participant said some people don't even like to see a counselor or a psychiatric or a psychologist. Like right now, I'm taking a course in counseling psychology, and then I realized that most of our people, they don't even go for counseling. Maybe when they're stressed or when they're having anxiety or when they're depressed or when they go to church, they think they can just dance it off. So again, there is this whole internalization around how am I going to be perceived? I'm not going to be perceived very well. I'm not going to seek services. I'm just going to try and medicate this in the best way, I think, which, you know, for this particular person, it's, you know, maybe going to church and allowing, you know, spiritualism to provide some intervention, which it can, but it's not as targeted. Stigma also manifested itself in terms of gender stigma. This particular participant had issues with receiving culturally sensitive care when it came to STBBI testing, by saying going to your doctor and talking about like getting tested for STBBIs can be really difficult, especially if the doctor doesn't, especially if you don't like a doctor that's really cool with that kind of stuff. Like I heard from a lot of people that doctors will say, oh, you don't need those tests. You're a good girl. Like you don't need those tests. Why would you need those tests? Having these tests done in a kind of informal setting, I think will help address the stigma and combat it. So when we look at the Levesque model, this is just highlighting that within the system-facing issues, there's this issue of acceptability, you know, really accepting where the patient's at and providing the care that is necessary and appropriate. And we see this also on a institutional level as well. When it comes to stigma, there's multiple taboo topics. As I mentioned, within the data set for the focus groups, there was an emerging set of themes around the fact that we're in COVID, we're isolated, we can't talk about a lot of issues that we're facing, particularly around domestic abuse. A lot of people were at home with their partners and experienced a lot more intimate partner violence. There's a lot more substance abuse. And so you can just imagine when people are cocooned and they have nowhere to go, they have no one to speak to, these sorts of issues escalated. And so we saw that specifically within the ACB community. And so the stigma from HIV just kind of accentuated some of these other taboo topics that we don't typically talk about. And so this one participant said, I can speak to Black women. We don't generally go and tell people when our relationships are abusive or our partners are abusive. We've been socialized to keep what happens in your home secret. Keep what happens in your home private, and don't tell everybody that your husband is an alcoholic or the financial abuse. So this was, again, we had a lot of quotes around domestic abuse that was happening at the intersection of COVID and at the intersection of STBBI. So when it comes to discrimination on a systemic level, there were multiple layers, predominantly around job insecurity as well as financial vulnerability. And so when we look at it from that Levesque framework that I mentioned, there's a huge issue around a patient's ability to pay for services or even seek services, right? And then there is that whole piece around accessibility. Services aren't accessible if people are losing their jobs, which we saw a lot within COVID. And then finally, all of these different pieces around stigma, whether it's internally experienced or within the community, as well as discrimination, whether it's happening at that systemic level, all of these pieces impact access to care. And so particularly when we had the pandemic closures of clinics, a lot of people could not access care in the way that they needed to, which for some, unfortunately, progressed their disease. And so these are issues that, we have to wrestle with as researchers, as, people who have loved ones in the community that are dealing with HIV, as to how do we provide support for them? How do we provide that safe space that they need so that they can feel comfortable even speaking about how they're feeling, right? So these are some of the thoughts I just want to leave with you as I'm wrapping up. So moving forward, as I mentioned, when we're dealing with these wicked problems, it really does require a village, a collaborative and strategic village to address these issues. And so I'm going to spend a little bit of time talking about policies that need to change, specifically around anti-racism or anti-Black racism. There was a lot of discussion, especially post George Floyd, about equity, diversity, and inclusion policies that were springing up in different organizations. But what we really need to see happen in terms of affecting real change is how are these processes, what are the processes that are involved in bringing these policies together? What is involved? How do you define race? How do you define anti-racism? Who are the members that are sitting at the table putting these policies together? What do the processes look like to actually impact change? And so when we talk about, addressing anti-Black racism, we actually have to get to the root of these policies in terms of how they're designed, how they're being implemented, who's evaluating them, how are they being evaluated, and what's happening on the other side of it. Like, are there specific programs? Are there specific funding models that are associated with these anti-racism policies to actually drive change? Because if you just have a policy on your organizational wall about anti-racism and there's nothing being done, then it's serving no one, right? And so these were some of the themes that came out of our data set, and we're seeing that also align with the research. The other piece that's very important, and I talked about it earlier in terms of a peer equity navigation model, is the inclusion of ACB voices in social programs that tackle these issues: mental health, substance abuse, STBBI. And the reason why that is so important is because it allows for that knowledge translation to occur at a very community level, as well as engendering trust and engagement, the engagement piece being very critical for our ACB community members to feel welcome into the healthcare space. And we know that there's been a lot of fragments as a result of COVID. And then last but not least, cultural competent tools for service providers. So currently right now within our lab, we have a critical health and racial literacy program that we're running for service providers across Ontario. We have we've trained over 150 service providers, and very happy about that, and it's growing. So this is one of the ways where out of the pandemic, we're seeing these little fruits being created or developed around ACB, culturally competent tools for service providers. So no one is left at an excuse to say they don't know where to get these tools, because they're in development or they're being implemented as we speak. So I'll leave it there, and thanks so much for your attention. And this was a great talk.